Hey everyone, my name is Chris and welcome to RSCP High Yield Concepts in Radiology. Today I will be going over bowel perforations. A bowel perforation is when an insult occurs to the bowel wall mucosa, causing free gas to enter the extraluminal space. There are a myriad of causes that can lead to perforations, such as iatrogenic causes, like when a surgeon accidentally nicks the bowel during a surgery, or if a perforation occurs during insufflation from endoscopy or colonoscopy. Trauma, different GI pathologies, cancerous masses that penetrate deeply in the bowel, and complicated bowel obstructions. Typically, when patients present with a perforation, they can present in various ways. Some patients can have acute abdominal or chest pain, while others can be asymptomatic. If a patient has immediate pain after surgery or a procedure like an endoscopy or colonoscopy, spillage of GI contents in air can lead to irritation to the mediastinum or visceral peritoneum in the abdomen, which can lead to acute constant pain. Pain can also radiate to the shoulder if the diaphragm is involved, and this would be through irritation of the phrenic nerve. Perforations can also cause abscesses and lead to phlegmon and intestinal fistulas, and this would present indolently. If a patient has a perforation above the diaphragm, like an esophageal rupture, this can lead to free air in the chest, causing chest pain, while any perforations below the diaphragm can cause abdominal pain and occasionally shoulder pain. Depending on the severity of the perforation, a physical exam can be quite important. If a patient becomes peritonitic or hemodynamically unstable, this would be a surgical emergency, and this patient should go directly to the OR. If gas is present in the neck or chest, you can auscultate and percuss these areas to assess for signs of effusion. Hammond's sign is a classic physical exam finding when gas is present in the mediastinum, usually secondary to an esophageal perforation, and you would be able to appreciate a systolic crunch at the cardiac apex. And like I said before, abdominal pain may or may not be present depending on how severe the perforation is. Some important labs to obtain are CBC and CMP to assess for whether the patient has an elevated white count, anemia, or any abnormalities in electrolytes or LFTs, lactate to assess for sepsis risk, amylase, which is generally elevated secondary to absorption of this enzyme in the intestines, lipase to rule out pancreatitis, and CRP to assess the extent of inflammation. When your clinical suspicion for perforation is high, you should immediately order an upright abdominal film, or KUB. This allows you to see whether there is free gas present in the abdomen. A few common pneumoperitoneum signs on the KUB are free gas under the diaphragm, Rigler sign, cupola sign, psoas sign, and Eurachus sign, and I'll show a few examples of these in the next few slides. A KUB does have its limitations, although it can help diagnose pneumoperitoneums about 90% of the time. If your clinical suspicion for a perf is high, but you can't see free air on the KUB, you still can't rule out a perforation. This is where a CT scan can be helpful. Not only is it more sensitive than an X-ray, but it can also provide more evidence on where the perforation is and some more information on what may have caused the perf in the first place. If a patient takes oral contrast, you may also see extraluminal contrast on the CT from GI spillage. Now I'm going to go over a few findings of a GI perf on a KUB. So here's an upright KUB, and you can definitely appreciate this radiolucency below the right hemidiaphragm, which indicates that there was a perforation below the diaphragm. Here's an example of the continuous diaphragm sign, which is essentially when the central part of the diaphragm, which usually cannot be seen in a normal patient, is seen due to the presence of free gas. The continuous diaphragm sign can be present in both pneumoperitoneum and pneumomediastinum, depending on which side of the diaphragm the free gas is in. In this case, this sign was seen due to pneumoperitoneum. The Rigler sign, which is also known as the double wall sign, shows a separation between extraluminal free air and the intraluminal intestinal walls. Normally on a KUB, only the intraluminal mucosal surface of the bowel is visualized, and this is because of the air and soft tissue interface. So when a perforation occurs and when gas becomes present in the peritoneal cavity outlining the bowel, both extraluminal and intraluminal layers can be seen. Here you can definitely appreciate the radiolucency of the air on both sides of the intestinal wall. The management for bowel perforations depend on how stable the patient is. If the perforation is small and if the patient is stable, you can treat them with broad spectrum antibiotics. And so since this is a GI etiology, you definitely want to cover your gram negatives and your anaerobes. If you're concerned about Pseudomonas, you can use cefepime for gram-negative and Pseudomonas coverage, and then metronidazole for anaerobe coverage. An NG decompression and MPO diet is also recommended. If the patient is hemodynamically unstable, then you should send this patient directly to the OR. And these are my references, and I want to give a special thanks to Dr. Kevin Hyatt for the images and his guidance. Thanks.